active. It's an active inflammation. It's by no means a dead, pathology. It's an active pathology, and I think this area is called the absorption zone. So it's full of macrophages and cytokines. So there'll be, I think I should probably do it from down there. So there'll be macrophages and inflammatory cytokines to keep, to propagate the inflammatory response, that inflammation which keeps this walled off. And then the next layer that will be seen under the microscope will be the lymphocytic layer with a lot of lymphocytes, and this is called the granule zone. And this is a TH4, a CD4 positive response. I think I need to do it down there just to make life a bit easier. So this is a CD4 positive T helper response. So we're talking TH2 response. So from this zone, again, this is active because of, if I do it in terms of cytokines from the macrophages activating the T lymphocytes, and then the T lymphocyte cytokines again activating macrophages. So we have that area there of continued inflammation. And then the outermost area is just fibrosis, really, and collagen. And this is, I would say, really the oldest part. So it's as if turnover, as things turn over, they push out, if that makes sense. So the new, it sort of pushes out, but the general, the general aim is to keep that in there. That is what's activating that area of death in the middle, is keeping the inflammatory response going on. So this is the oldest zone. So this is what it will look like under the microscope if you were to look at one of these nodules, just to see what it looked like from a biopsy. Usually that's what they look like. And then in terms of how to treat these conditions, the treatment is usually specific to the disease. For example, say conditions like SLE will need steroids, corticosteroids. Idiopathic will need the treatment of underlying condition. And so forth. So I can't really say what specific treatment is. I'll just say treatment is managing specific disease. For example, if they are connective tissue, they would usually need corticosteroids like prednisone. Connective. They would usually need I'll say yes. And then usually the complication of restrictive lung disease, so the complications are usually core pulmonary. Again, it's developing a heart condition because of the failure of the respiratory system, which then causes respiratory failure and can indeed lead to death or that has to be managed as well. So really this is how we would talk about interstitial lung disease, and talk about how to manage them. So in this section I've talked about what restrictive lung diseases are, including all the ones that affect the thoracic wall, including the pleura and the bones, including the ribs. Well, just introduce what they are in terms of those. I've then also specifically discussed the interstitial lung diseases and use sarcoidosis mostly as an example, and also mentioned that idiopathic, for example, happens in older people, and then defines the classes, for example, that they are collagen specific ones, they are vasculitis, they are they are drug induced, all the different classes. I've also discussed how they affect lung volumes and what lung volumes are, and indeed discuss what the restrictive pattern is itself. So whilst we are talking about restrictive lung disease, I'll just quickly discuss conditions of the thoracic wall. I think that's important to briefly touch on that. I'm not going to talk about them a lot, but thoracic wall, because they can cause restriction in terms of reducing lung capacities. So when we talk about thoracic wall, it can be neuromuscular, it can also be diseases of the pleura, and also kyphosis. I'm trying to think if I've forgotten anything. So in terms of kyphoscoliosis, really, it's congenital deformities that are best corrected in childhood. Because if not, they will lead to severe restriction and early death. And when I say, things like scoliosis, if you can imagine the lungs something pressing on the lungs, a deformity that reduces the thoracic wall and causes the lungs to be deformed and reduced in size. So this is not a pathology of the parenchyma or the alveoli, it's just the thoracic wall itself. Say if this was the normal size thoracic wall, it's just disorders that reduce the capacity and the volume and cause the thoracic wall to be smaller than normal. Therefore, as a person grows older, their metabolic needs and demands increase, so that cannot be met by a smaller volume. And then neuromuscular, again, it's the breathing muscles and the respiratory center, or indeed just the breathing muscles. Again, they could be neurological on their own, which is the breathing center, but the neuromuscular, again, is the messaging from the central nervous system to the muscle that fails, say in conditions such as in myopathies and in myasthenia gravis, perhaps. Guillain-Barré, and MS, I think. Yeah, auto. No, let's just leave it at that. So anything really that disrupts that messaging from the central nervous system to the muscle, because if you can remember, the brain will give a message to the muscle, and the muscle reacts and feeds back to the brain. So anything really that disrupts that feedback system, which causes the working of the muscles, will cause eventually muscle wasting if there are muscles that are not being used, and obviously if it's breathing muscles, which will include the interthoracic muscles and the diaphragm and the accessory muscles as well, which include the sternocleidomastoid, the anterior vert, which are the scallion really muscles. So anything really that causes failure in the way these muscles are supposed to work, and indeed the vertebral, in terms of pushing back from the spine in scoliosis. And then another condition which causes a restrictive pattern, but that's reduced, is ankylosing. I just thought about it, ankle spondylitis, which does not which it doesn't cause too much of restriction. So restriction is causes limited restriction, but only because the diaphragm compensates for its the failure that's caused, compensation. However, if a neuromuscular disease was to happen, that would cause failure of the movement of the diaphragm, then you can see how this can then cause the pathology to be more pronounced and worsen. And then other thoracic wall pathologies include the pathologies from the pleura, which will include cancer, which is oh God, I'm so bad at this, mesothelia, which actually affects the cancer of the pleura, shall we say cancer of the pleura, in case I got that. Mesothelia. Yeah, it is mesothelia. That's fine. Pleura. And then conditions such as pleurisy, which is pain on inspiration and coughing. Again, this can arise from an infection, and you can imagine if this was someone with an infection and they're not coughing terribly well due to the pain in their pleura, then they could end up with, this can then progress to a serious pneumonia if they can't cough up pathogens. So pleurisy just reduces the movement of the wall because of that pain. It's like someone avoiding movement due to the pain they feel. I'm also thinking about things like infiltration, as in having fluid in the pleura. So the fluid in the pleura can come from an inflammatory process causing inflammation, or an infection, again, leading to infiltration, but really it's the fluid in the pleura. Fluids in the pleura can be perhaps blood, which would be a hemothorax. It can be paima, which is just pus-filled fluid, usually due to inflammation. Other fluids in the pleura can be exudates or indeed transudates. When we say exudates, we mean the fluid buildup that arises from a pathology within the lung. So this is intrapleural. And I really need to just talk very briefly that if we remember, we have parietal pleura on the outside, and we have visceral pleura, which is attached to the lung. So this is the lung. You can't really separate the visceral pleura from the lung. And what I'm talking about here, this fluid is intrapleural, in the pleural space. That's fluid in the pleural space, because if we remember that this layer there in between is a potential space. So fluid can build up in there, and obviously that build up of fluid, as fluid builds up in the pleura, depending on the amount of fluid, it can then push, okay, I've done it in red, okay, it can then push the visceral pleura and the parietal pleura, increasing that space, and in doing so, if these were normal lungs sitting there, so obviously the pleural space is just there. So if as this fluid builds up, it will take up room. It needs room to expand into, and what it does is the parietal pleura remains there, and this lung collapses on itself because of that pressure from this fluid. So it will collapse on itself and take up less room. I don't know how to draw it properly, just to show the point. So if this is a lung that previously, obviously I've exaggerated this a bit. So this is a lung that previously occupied all of that space. So now it's occupying far less space, and there is now space intrapleurally. So this fluid can either be an exudate, which means it comes from within the pleura, and usually it is due to things like infection and inflammation within the pleura, And we identify fluid in the pleural using radiology, and fluid only becomes visible radiology when there is more than 300 ml of fluid in the pleural space. So you in order to differentiate between an exudate and transudate, you aspirate a bit of fluid to find out its protein contents, and if the protein content is more than 30 milligrams or millimoles, what do I call it? I've forgotten. Per liter, then it's an exudate. And also you have to check the, I think it's lactate. I should have dehydrogenase, and it has to be increased. I think it has to be more than 200 international units per liter. And if you get it has to be more for it to be an exudate, which means it's intra-pleurally or intra-pulmonary, really. So it can be things within the lung, or even a cancer, but it's a pathology that's within the lung. So the transudates will be just different, less than 30 mils of protein. This is protein there, and less than 200 international units of lactate dehydrogenase. Whereas the exudates will be more. There will be a lot of protein. So in terms of so the things which cause transudates are things like heart failure and kidney disease, usually nephrotic disease, really, nephrotic disease of the kidney, nephrotic, and I think thyroid disorders. Will cause transudates. So this is fluid that's arising extra pulmonary, and it is indeed called, if I just say intra pull, extra pull. So the best thing to do really is to treat the underlying condition in order to resolve. However, if this fluid is an exudate arising from a pneumonia, and is purulent, then it must be aspirated and treated with antibiotics. So that is fluid in the pleural space. Just in brief, really an overview without doing it too much. And then how you would in radiology, as you see that fluid, it becomes much more visible when it's much more than 300 milliliters. And one of the defining features that there is fluid in the pleura is the blunting of the costophrenic angles. So they will blunt or disappear. So what I mean by that is that when you look at a radiology film of the lungs, this being the right lung, and this being the left lung. The diaphragm lies there. And usually, you see an angle there which follows, the outline of the lung and the outline of the diaphragm, and that is called the costophrenic angle. Phrenic angle. So when there is fluid, fluid builds up. So it causes, it covers that. It diminishes the appearance of the costophrenic angle at the affected side. So this one might still remain. You might still see the one on the left if it's a right-sided pneumonia, let's just say. So the one on the left will still be present, and this one would have diminished, and there will be a fluid level as well. So then that helps, or fluid in the lung fissures as well, and there will be Kelly B lines as well, just to show that there is fluid buildup in that lung, because Kelly B lines really are due to edema, and obviously anything that's wet, that's fluid, that's edema building up in the pleural space. I've just realized that when I was talking about the interstitial lung disease, I forgot that there's crackles on inspiration as one of the diagnostic features, because really with edema, fluid in the lungs, there will be crackles as well. So I've just remembered that. So you'll see the blending of the costophrenic angles on radiology. And then another condition to mention in terms of the pleura is pneumothoraxes. Which is just air in the pleural space. Pneumothoraxes usually affect younger males who are tall and thin. If you think basketball player, that's how I normally think of them. I know it sounds really awful, but it makes thinking about people, about who is affected, much easier. And it's usually due to a congenital disorder of connective tissue, specifically affecting the apexes of the lung. And what it causes blebs. And blebs really is just an air pocket. And when that air pocket bursts, like when it ruptures, then you get a little bit of air. Then you get, so this is an air pocket, which is just sitting there. Let's just say this was just a lung, and then, so obviously lung undergoes respiration. There's always air moving in and out of the lung. So that air pocket, because of that loose connective tissue there, you have an air pocket, and then if it ruptures, then that air enters the pleural space there, because it has to go somewhere. So it enters the pleural space because that's a potential space that's always there and available, leading to a pneumothorax. So pneumothoraxes from these can, be a small pneumothorax, and they will present with all pneumothorax with increasing dyspnea, so that's the first thing, that's the most common presenting feature, that is an increasing dyspnea. There will be other, you know, things like pain, but you know, leading to tiredness because there's no someone who's breathing as well as they should. But increasing dyspnea is the characteristic feature. So if you were to do they're diagnosed via radiology, or sometimes if it's someone who is prone to having the pneumothoraxes, or if it's someone, you know, who is a younger male, they're tall, they're thick, sorry, they're tall and they're thin, then there's a potential that it's a pneumothorax, and based on the clinical picture as well. So really, do a radiology, it finds loss of lung fields, and obviously that, you know, air in the lungs, which is just dark. I don't know if I'm spelling things correctly. Fields and, you know, air in the lungs, which is dark. And if it's just a small pneumothorax, it can be, you know, just manage the patient with analgesia and oxygen therapy, and you know, just give supportive treatment, supportive therapy until it resorbs, which can happen. So it will reabsorb or resorption, but then review to make sure that all is well. A pneumothorax can also be larger. Again, it's the same thing really, where air is introduced into the pleural space, and introduction of air, it doesn't matter where it's coming from, causes positive pressure in between the pleura, because the pleura naturally has negative pressure. So introduction of positive pressure then means that as you breathe in, I should use a different color to differentiate things. So pleura space, normally negative pressure, but introduction of air, it's much more pronounced in larger pneumothoraxes. So introduction of air into potential space, cavity, I would say potential pleural cavity, which is the pleural cavity, causes positive pressure. And then there's one during breathing, the positive pressure increases and it causes the lung to collapse due to its elastic recoil pressure. So it's pressures again. So introducing air into the lung, this is more pronounced obviously on larger pneumothoraxes, introducing that positive pressure, and that positive pressure then causes the lung to collapse. This happens with it will happen with a smaller, but small pneumothoraxes are much more, you know, they're not as pronounced. Of course, the pathogenesis, the underlying pathogenesis is similar, but if it's something, a tiny bit of air coming from a blip, it's not going to be as much, the collapse of the lung is not going to be as much as the increased pressure from the outside, which can be, say, anything really, perhaps a stab or broken ribs, that just introducing air into the pleura.